when lightning strikes twice in the case of anemia. So this slide is just talking about a few different causes of anemia and their incidence with a little foreshadowing mixed in. So B12 anemia is present in 1.4% of the general population, so something that's quite common. Then you'll see folate deficiency about a third as often. As you can tell from the pie chart, warm autoimmune hemolytic anemia is present much less often, with incidence of 0.017% in the general population. So our case report starts with a 65-year-old female presenting with symptoms of fatigue and dyspnea on exertion with a slow, insidious onset. She denied bleeding from any orifice. She denied dietary restrictions or deficiencies. She was not a vegan or a vegetarian. However, the key thing here is she admitted to a remote history of anemia that had never been fully worked up. On history, past medical history of insulin-dependent type 2 diabetes as well as hypothyroidism. She denied smoking, drinking, or illicit drug use. She was somewhat fit, worked at an assisted living facility as a caretaker on her feet all the time. Her medications included 10 units of long-acting insulin daily and Tresiba. Physical exam, however, was benign. Vital signs were stable. There was no noticeable pallor, no glossitis, no tachycardia, no murmurs, no hepatosplenomegaly. So our initial workup did reveal that she had pancytopenia with a macrocytosis. This prompted us to look at B12 and methylmalonic acid. The B12 was low and the methylmalonic acid was high, indicating B12 deficiency anemia. And then we did intrinsic factor immunoassay. However, that was negative, so unlikely to be pernicious anemia at this point. The patient was subsequently admitted and treated with 2 units of packed red blood cells for symptomatic relief. However, the etiology of B12 anemia was still uncertain, so we did further investigation. We ordered a peripheral smear, an EGD, and hemolysis labs are also suggested, so we went ahead and ordered those as well. Now, this isn't the actual peripheral smear. We're still waiting on the report to come back for that, or the actual image to come back. However, this does match the pathology written report. So we went ahead and pulled this. You can see the red blood cells are as large as that lymphocyte there, indicating macrocytosis. And then also on the top right, we have a hypersegmented neutrophil, indicating megaloblastic anemia as well. And then here we have the EGD results. Again, this is not the actual histologic slide, but it does match the written pathology report of chronic atrophic gastritis with metaplasia in the antrum of the stomach, no evidence of H. pylori. So the metaplasia would mean less parietal cells, less intrinsic factor, less absorption of B12, which fits with our current picture. And then her hemolysis labs, interestingly, came back at that point after we thought we had it all pinned down and showed a low haptoglobin of 8 and an elevated LDH of 5,561, which was odd. It did not fit with the absolute reticulocyte count at 0.13%. So it was kind of a partial picture of autoimmune hemolytic anemia at this point. We went ahead and ordered the direct Coombs test and direct antigen test, which both revealed the presence of autoimmune hemolytic anemia with IgG, so therefore warm autoimmune hemolytic anemia. Each of these 2 separate causes of anemia occurring independently and simultaneously in the general population would happen only once in every 420,000 people. Episodes of pernicious anemia are autoimmune related, as are cases of autoimmune hemolytic anemia, and therefore unsurprisingly there are a few cases reported in the literature of these occurring together. And while the sensitivity of our intrinsic factor immunoassay leaves ample room for speculation, our case may represent a novel situation where a non-autoimmune B12 deficiency anemia went hand in hand with an autoimmune hemolytic anemia, which would be a true instance of lightning striking twice in the case of anemia. And finally, here are our references.